Well, as you can see, there's we presenters. This is my friend Brianna Kirkland. She's in spirit. Let me get over to this next slide. Okay. So just to give a little background about myself, I am with Kaiser Permanente in southern Colorado, and I have been with them for about, I'm going on my 7th year. And with Kaiser, and when I first got there, I was going, palliative care? What is palliative care? I had no clue, but I learned really fast. And Sangre Cristo Hospice, they are also located in southern Colorado. And when I first arrived and started building the program in southern Colorado, I started networking and getting my fingers out there and meeting people. And they were one of my really strong partners that we developed a good relationship. So I thought when I went and learned advanced steps with Bridget Darden and in Colorado, and I said, I know how to have these conversations. Why do I need to learn advanced steps with respecting choices? I was very resistive. But I went and I learned at the high suggestion of my manager and absolutely loved these conversations. It just resonated, the power that it gave people. It empowered them to make their own decisions, to be able to know what they want and having their wishes honored. That was so powerful. So in my infinite wisdom said, I need everybody trained. I want everybody in southern Colorado to be out here doing these conversations with people. So I thought, okay, I'm going to my buddies over at Sangre, and I'm going to ask them to all come to my next training, because I then had become a trained instructor, as long as was a facilitator, and asked them to show up. Well, Brianna says, I'll come because I'm your friend. Social workers are quite the master manipulators, if you don't know that. So Brianna and her cohorts, she brought over, how many were there? About 12 that came over?
16.
16 total, but 12 from Sangre came over for the training for advanced steps. We call it advanced steps, means last steps. Same thing. And Brianna said the same thing. I know how to have these conversations. But she went through it, she went and tried it on, and had 2 or 3 conversations with a couple of people using the model, and it impacted her. She's the senior vice president for Sangre de Cristo Hospice and believes in the process now and very invested. So she also came on and learned and became an instructor as well as a facilitator. In first steps and advanced steps. I'm an instructor for first, next, and last, as well as I'm just became a certified organizational faculty for first and next. And I also do palliative care in Southern Colorado. By myself. But anyway, we wanted to light a fire for life care planning in Southern Colorado. And first we went to Triple Aim. Said, hey, what do you think about this? And we're telling them about the conversations and how we could get out in the community and spread the word. And why does everybody think when we get a grant that everybody wants a piece of it? So we brainstormed and thought about it. But first, before we brainstormed, I want to show you a picture of our beautiful state. This is in southern Colorado. It's a mountain lake. And it's one of the deepest lakes in Colorado. So you don't go swimming in this lake. But I go hiking up there quite a bit. And it's very near where Brianna Kirkland lives. So we got together and we started brainstorming, and Tammy Kelly from the project manager at Colorado KP said, hey, there's a grant out there called the Colorado Health Foundation Grant. Why don't you guys apply for that? Not me, but why don't you at Sangre de Cristo Hospice apply for this grant? And Brianna said, yeah, that's a really good idea. So we started having some meetings together with Bridget and Tammy and Patty and myself, and thought of how we could implement this grant and write it up for life care planning spread in Southern Colorado to community partners. Well, with that said, we thought, and we said, okay, we could do this, and we can plan, we can think about it. So we met probably that first couple months before the grant was due, yeah, and several times. And then after they actually received the grant, then we met about monthly. And then the second year we met quarterly because it was a 2-year grant. And thought, geez, we could not only go to hospitals, we could go to universities, we could go to community colleges, we could go to primary care clinics, the community health centers. So that's how the grant was developed, as well as the spiritual community. We thought that was really important as well, and how to implement this. Well, after we put it in, it was approved. And they were awarded a 2-year, $100,000 grant to spread this work. And so life care planning began. Kaiser promised me, as part of the in-kind, to help train facilitators and to get them certified, to get the word out. So that was kind of my job. This is the service area. I wanted to share the part of Colorado that there were, and if you don't know where Denver is, it's up here. And we're down here in southern Colorado. Pueblo is where we're based. And we were able to spread the work with these first 2 years in Fremont County to Pueblo County, Custer, Huerfano, Otero, Bent, and Los Animas, and a little bit of Chaffee. We didn't get too far into Chaffee County. But for 2 years, that was quite the spread, and a lot of work, a lot of hours. But we thought, we could really target a lot of people. We could get a lot of facilitators trained. We could do all these things. But we really need to see where it needs to be first and get the right people trained as facilitators, and just instead of saying, let's get everybody trained. Because that doesn't work. You need to assess the readiness of that facilitator. Do they want to do this work? Do they have the passion for it? I think that's really important. And where do their strengths lie? Do they have connections in the spiritual community? Do they have connections in the community health centers? What are their strengths? So that's what we started doing, is looking at that to target the right people for the right fit. We also spoke to some of the CEOs of the local hospitals. This is some information from just one of the hospitals of the Medicare and Medicaid population in the southern Colorado area for just Pueblo. They have in 2016, they had 41,362 calls for service of that population. And of those, just under 10,000, a little under 10,000 were actually transported, the 31,000. So 10,000 weren't. So that tells you how busy those hospitals can be, and probably a lot of them could have been avoided had they had an advanced care planning conversation to talk about their goals of care. What do they want? This is the Pueblo office. You're going to see some of these offices, you're going to go, my goodness, they are really rural. We are. Very rural. But in the Pueblo area, what we targeted were the first responders, the university and community college nursing students. My next plan is to get out there and target the social work students, because I think they need this as well. Churches, and then families of individuals who entered hospice care. So to target them, because they need to start their advanced care planning as well. And with that, with the first responders, I helped Brianna with that training, and we went out and did a training where we gave them an idea of what is a MOST form. We call it MOST in Colorado, the pulse paradigm. And we did over 110 firefighters and 11 different workshops in 2 months. And in every single workshop that we did, 1 to 2 firefighters actually have completed their own advance directive. Did not realize we were not a next of kin state. One firefighter said, "You mean my ex-wife could come in there and start making decisions?" I said, "Yeah, they could assign her, absolutely, by a proxy." So I think that was really enlightening to them, as well as it was amazing when we went through the actual MOST form with them and how to interpret the order, how many different responses we got for different situations. We did this in the ED with the ED physicians as well, just to go over on how to interpret. They even had confusion. So it's an ongoing education process. We can't just stop with that one time. It has to be ongoing, is what we determined. So that's one of the things that we're going to continue with this, even when the grant is no longer, because there's turnover, especially in the ED. Those physicians are in and out, in and out. In the university and college students, that one was very powerful because many of the nursing students didn't realize about advance directives. They went through an actual first steps class within their class and then completed their own basic advance directive. And later I'm going to share with some of the quotes with what some of those students said. So it was impactful. And in fact, one of the outcomes of the university is they've made it now a part of their core curriculum, which is huge. So there's Pueblo. I go to that office quite a bit with them, talk to them. This is the office in Walsenburg. It's in the southern part, it's almost to the New Mexico border. In that office, they targeted the primary care clinics. And one of the physicians, Dr. Story, after they did some education, I say they because Sangre, Brianna, and the gal that we trained for First Steps, she went in and did an actual training for all the primary care physicians in that office to let them know what this was about, what they had planned to do. That physician started referring every single person that came in for their annual wellness. That physician's office now has 100% of patients that come through there completing their advance directive, and it's now stored in their medical record. So getting the buy-in, I think that is the big piece. Educating before you go out there and just start doing, but letting them know what you're going to do and why you're doing it. Getting the buy-in in, because that is huge. They also have library events every single month to where they're open to the community to come in and learn about first steps in completing a basic advance directive and learning about why it's important to make these decisions and what decisions they need to think about outcomes in the case of that unexpected neurological event. Little tiny office, but doing powerful things. This is the office in Otero County in La Junta. This office, they targeted a community college in there because there's a local, pretty robust nursing program in this community college. They targeted this one, and each class, again, went through a First Steps class, completed their own basic advance directive. And the feedback from the students at this college is, I never realized how important this is. Another student said, I will take this into my work as a nurse in the future. So starting with that, think about it. They touched maybe 25 students each class. And of those 25 students, think of all the people they're going to touch. That's why we say it's spreading like wildfire. We don't want real fire, we want, but we want a fire for life care plan. Yes?
Can you tell me exactly what training that you did with these folks?
We went in and, well, we started with the actual nursing director of the school and talked to her about what we wanted to do, talked about the First Steps class that we actually have with the community, And that's pretty much the class that we did with the nursing students, First Steps class. And that's the class that they now have, as well as took it a step further, and we talked about how to interpret the most and when you would do a most conversation, the advanced steps conversation.
So they come out as First Steps facilitator, certified facilitators,
Yes.
and they've got some exposure to most.
Yes.
It's really about starting with leadership of any community, whether it's, the head librarian or the chief physician.
Well, with the fire department, we started out with the fire chief and went and talked with him. In fact, that was about 3 or 4 conversations with him before we were able to get into the workshops. I know that in Denver, they've tried to model this exact same process with the fire department, with the first responders, and have met a lot of roadblocks, I think, with the health
Their
department.
union and the health department's having some issues.
Yeah.
We're still working on it. That's one thing Colorado does to us.
Yeah, we don't give up, we're persistent.
Did you, to like pay for the online modules and that, did you use grant money or did they pay?
They use the grant money for the online modules. Yes.
So, one more question, what are they doing now then that the grant is done for the nursing students and they're still have it in the curriculum?
Well, that's a really good question. Hopefully, I don't know the answer to that. Brianna would know the answer to that. But I do know that they had quite a bit of money left over at the end of the grant period, and we're planning to purchase additional seats for future use. So that may be how they're going to do it. I am not sure. I apologize.
Is your goal then for them, if they're facilitator trained, is the goal just so they have that awareness versus some of us that think of facilitators as those that are using that and reporting those metrics, like we do for the normal 6-month pilot, is it just it's better for them to know than not know kind of a facilitator training?
That's more of what it was, absolutely. We're hoping that they take it out there and become a facilitator within their own realm of wherever they go. But there's no way to track that. No. Unfortunately. That would be nice.
And with the firefighters and the fire chief, was that just like an awareness campaign, like this most exists and here's what it's about and here's how to use it when you see it? Or were you actually trying to do something different with them?
It was education. Total education. Dr. Dan Johnson, I don't know if you guys know that name in this room. A lot of people do. He's a palliative care physician that is known statewide, nationwide. He developed an actual PowerPoint for the education of how to interpret the most, why we do a most, where do you find the most in the room. Physicians, back to the firefighters and their first responders, they didn't even know where to look for this document. And one of the reasons we wanted to target them is I go out into people's homes a lot for palliative care. And I talk with them and I have these conversations with them and I tell them, put this on your refrigerator, or if you're really serious, put it above your bed, somewhere where they can see it. And it was amazing that one of the people that I went to their house, they said, you told us to put this here, but they started CPR and didn't go look for the document. I had to go grab it off the fridge, but if I hadn't been here, what would have happened? So that was one of the reasons why we really wanted to target the first responders, so that they would know to look for these documents and what they meant and how to interpret them. And this is another one of the rural offices. Hello. Well, maybe.
Oh, there it is.
Did it come back? Okay. Whoa. Safety conversation. We have those in Kaiser all the time. Safety conversations. Don't jump off the steps. These are some of the facilitators that were trained. We targeted one of the folks that we trained. He actually is in the part of the Ministerial Alliance. So that was an avenue to get into the spiritual communities. Because I tell you, we have had so many First Steps classes and conversations in the churches. and so well received. That's so powerful. Because I know I've had conversations with people, and they're like, I don't know what I want. And I'd come back 2 or 3 times, and one patient, when I came back, I said, did you talk to your spiritual advisor? Did you talk to your pastor? Because they were really wrestling with some of the decisions. And they came back and they said, I did. That's how I finally came to a decision. So I think that's another really good place to also start having these conversations. We trained a respiratory therapist because she goes into a lot of those homes with people. And that's impactful. And she has that verbiage to really help with some of the more difficult, challenging conversations with people that have COPD, which we have a lot of in the Pueblo area. There was a steel mill that was there, and a lot of the folks that are retired have a lot of lung disease. We also trained 2 of their volunteers. They go out into the community. So they're non-paid. They go out into the community and they talk to everybody. I have one that came to one of my classes so that she could learn how to do the class, to make sure she was doing it right after she went through the facilitation process to be a facilitator, to be certified. So that's some of them. But there were 13 First Steps facilitators that were trained in total over the 2 years that we handpicked and went through quite a process with them to make sure that they had a passion for this. We didn't want to waste the money. And we also trained 8 Advanced Steps or Last Steps facilitators. And of those, there's always turnover. But there's still, I think there's still 7 of the Advanced Steps facilitators that are still with, out there doing this in the community. One of the Advanced Steps facilitators went and started working for community health, and she's now doing this in the community health due to her training as a facilitator. So even if people leave, the work continues. And this is one of the community classes that was held at a senior fair. I use the Honoring Choices video in my class because I think it's very powerful. And then this is our first year results. It's really hard to see, I apologize. So I'm just going to kind of give you some highlights. After the first year, the implementation, we had over 200 community people that were reached and completed their advanced directive and returned it. So that encompassed the first responder workshops because a lot of them had not completed their advanced directive. So then those were also done. We had 3 waves of First Steps facilitator classes to become facilitators, and 1 class for the Advanced Steps or Last Steps class for facilitators. We had the university education. The specialties were targeted. Hospital ED, we provided education to the emergency departments, physicians, and home health agencies were targeted, not to become facilitators, but to provide education. We were seeing them completing most, like a checklist. And it would come back, and it would be incongruent. So targeting them to at least provide that basic education of what is a congruent form and to encourage them to refer to a facilitator to have these conversations instead of doing themselves. Because as we all know, skilled nursing facilities and home health agencies, that's part of their paperwork. That's part of our admissions packet. Let's get it done. So to encourage them to have these more robust conversations is really imperative. And then, into our final year results, we have 8 licensed professionals as advanced steps. We did not take anyone that did not have more of an advanced degree for either at least their bachelor's in social work, RN, or the respiratory therapist was one of them as well. And then we had 13 community members as First Steps facilitators trained. 102 one-on-one conversations that second year. 21 ongoing monthly classes, which I think is powerful. 280 healthcare students. And it's just, I just can't get over in Walsenburg how they had the one medical practice and it's at 100%, which I think is just fabulous. That truly is a testament of getting the buy-in of leadership.
So I have a question about that.
Mm-hmm.
So you said that now it's 100% get a referral at their wellness.
Mm-hmm.
So what does that mean by a referral? A referral to one of these? Or
One of these
are they-
facilitators
Oh, wow, okay.
tells them this person's going to call you, and then he sends the name directly, that medical office sends the name directly to that facilitator, and the facilitator outreaches or invites them to a class.
I have another question about
Mhm.
that. What is the target population for that? Is it 18 and above or 50 and above or
It's the Medicare annual wellness visit, so it's 65 and above.
65?
Yeah, we didn't want to do everybody because we don't have the capacity.
Right.
We had to start a little smaller, narrow the field.
You gotta identify your target.
Yes, absolutely. Trying to look at my notes. I should have brought my glasses up here.
Are these them right there?
Oh, thank you, dears.
Are you going to be able to continue these classes at all? What
Yep.
should we do?
Sangre de Cristo Hospice believes in this so much that they are now allowing their staff to do these classes once a month. The Kaiser Clinic office, we trained the LPNs to do the First Steps classes. So they're allowing once a month staff to come off the floor and teach those classes. And I'll tell you, the staff that do these classes love it. It makes them want to come to work again. So that's another powerful piece of it, is job satisfaction.
Talk a little bit about what happens at the monthly classes.
Mm-hmm. Yeah, at the monthly class, we actually have a PowerPoint that goes over what an advanced directive is. It's pretty much taking what you learn in the First Steps class, First Steps as a facilitator modules, and the actual class, taking those pieces and turning it into a PowerPoint in a group fashion. So you're looking at, why do I create a basic advanced directive? Why do I need to do this? Who can sign for me? Who should I choose to be a healthcare agent? What's the importance of choosing wisely? What are the reasons why I would want to do this? So we go over, this is if you have a serious neurological condition or something happened, like a car accident, and you need someone to step in and make decisions for you. What outcomes do you want? What do you want life to look like? So we go over what is living well and how it changes over time. Our health doesn't stay stagnant. I know I'm a lot different than when I was 18 compared to what I am now. Yes?
And I'll just add that on the instructor flash drive, there is a whole folder for group facilitation materials,
Oh, that's,
in case you haven't looked at your instructor flash drive for a while.
I highly recommend that.
Yes.
Their group conversation materials, and they're really effective. It feels like a one-on-one, but with a whole group of people.
and what we did is we took that and we fashioned it. We just changed it a little bit for Colorado law. Yes.
So one of the challenges we face in like primary care settings is that we'll get like one or two people who are really excited about the work and they really champion it, so you'll start to see some results, and then they leave. So like in the case of that physician who got that great result with the Medicare wellness visits, what sort of things have you put in place to make that sustainable beyond those individual docs? Like,
To make sure that we always have a facilitator available.
Exactly, just to make it
Yes.
easy for any physician to do that. Yeah.
What we've done there is Brianna has said as she will always be the backup. I'm a backup unless we go somewhere. We have a trained facilitator she is really in that area, loves the work. It keeps her job satisfaction. So she wants to stay because she can do this. That's why we trained several facilitators so that anybody could step in. I mean, that's a beauty about this work, is it's standardized.
So you have a plan to keep the facilitators always present, which is great. That's
Yes.
definitely been one of our challenges. What about on the physician side? Like, what have you done with their workflows, with their clinic routines, so that, again, like if that doctor leaves and another doctor comes in, that referrals process
Still
still
goes.
happens?
It's in the rooming process.
Okay. Oh, yeah. Very good. Yeah.
So part of the check-in, when they come into room, the MA or the LPN or whoever's checking them in, that's part of their standard workflow. That's one of the questions they ask.
That's so great.
And introduce the conversation
I'm
and give
gonna
them a
follow up on
flyer.
this 'cause we're just about to do this on a larger scale. So can you tell me a little bit about how you got buy-in to start that? Because we're competing with, like, there's so many questions people want asked during the rooming process. How did you get buy-in to actually make those changes happen to their rooming process?
I'm going to let Bridget talk a little bit about that. Come, you want a mic?
There's a microphone, but I would love to hear this.
There, Mike.
Oh, the podium mic. You get to stand up on the podium. I want her to talk about how she did this for Kaiser.
Yeah.
Do you mind? Do you like how I just put her on the spot?
Okay, can you hear me now? Yeah. Okay, so primary care has a lot of turnover in facilitators, and that's a basic nuance that you have to face. So you continually train, and we set up for advanced steps. I have a one-on-one going over the project plan with the manager. At that time, we go to the nurse manager meetings, and right now, because we are putting it into standard workflow, they're allotting X amount of time for standardized work that needs to get done, not if I got extra time, but I'm gonna have allotted time with the area administrators. And we have a very active executive sponsor team. I would highly suggest that for any of your organizations. So we have the CPMG leads, VPs in quality and innovations, and clinical care, and then we have the director of nursing, we have the VP for complex care, home rounding, supportive care, senior innovations. I mean, there's like 12 people on the executive team. And we made them sign a contract with us, a commitment agreement. We gave them all, Antoine, is that how you say his name? Atul?
Atul Gawande.
There you go. Atul Gawande, the book, and had them read it before they came in. And then we had a series of commitments that they had to initial off, just like buying a house. They were buying life care planning. And their responsibilities were to hold people accountable to life care planning. It's been a really hard journey this year. It's becoming a little easier because there is buy-in now. People are seeing it. I'm actually getting referrals from Kaiser docs in the hospital for non-Kaiser doc patients' mothers. So, I mean, it's been a lot of work. But I don't know if I answered your question.
No, that's actually good. So one of the first things you did was get that key leadership support.
Yep.
And you actually made them put it on paper that they were going to commit to and be held accountable for maintaining this program. So then at the clinic level, how did you get buy-in to change the rooming or add this question around advanced care, life care planning to the rooming process? So sort of how did you get that buy-in?
We kind of went through back doorway. We have in Epic, we had a care group built into the health track system. And now at Fires, we're starting with 4 of the big clinics for advanced steps and everybody for first steps. So we'll automatically fire for first steps care group 1 through 3. And if you're a care group 3, which is coming in the near future, with 2 or more hospitalizations in 6 months, you would be referred to next steps. And then care group 4 is advanced steps. So you refer to the advanced steps facilitator in the primary care clinic if they have one. Not all of them have them because some only have 1 RNs if they're smaller clinics. And I did try I tried 2 LPNs for advanced steps, and one I literally was by her side for about 8 months to make sure she stayed within her scope of practice. But she is one of our top facilitators for first and advanced steps. And the most successful clinics are the ones the manager sees the value of the whole conversation. And Patty and I, First Steps faculty and I, go out together now for implementation. And we make sure they involve their physician champion, the manager, their UBT, the unit-based teams. We make it a goal on their annual evaluation because UBT is always going to be on there. And there's so many different avenues you can take with those type of areas. So we go out and do a joint implementation and get a commitment. There are some clinics that have taken 2 years to get on board, but I will tell you, that clinic is the highest performing clinic now in the region. I mean, they're having over 20 people at their monthly classes, and they're doing, up to, for one facilitator, up to 10 advanced steps a month.
Yeah, so when they're ready, they're ready. So you just kind of persistently.
You
went
just
clinic by
keep
clinic,
going.
The leaders there to make
And so care group was our into the rooming process, and they wrote it into the rooming process without us knowing about it was written into the rooming process. And they developed this whole workflow, and Patty and I have been the past couple months doing a lot of cleanup work because professional development decided on the workflow, and it wasn't even close to what the workflow is. We didn't want to make it harder for them. We wanted them just to, check their health track like they're supposed to do every time. If they, were due for advanced care planning, to hand a flyer with the class and the website on it. And for advanced steps, hand the flyer, write on the vital sign face sheet for the doc, introduce advanced steps, and then refer. And we developed a centralized referral for hospital discharges because we don't own our hospitals. And anybody who doesn't have a facilitator. So Patty and I go out around the region from New Mexico to Wyoming to do conversations.
Yes.
I have a question. So in the workflow that you're talking about, is the proactive button, is that what you're using, like the one that says they need their mammogram?
Yep.
So
We call it health track.
So it's a proactive button.
Yep.
You had a question?
Actually, I was just gonna sort of comment, that even though Honor Pacific Northwest is a convener model, one of the ways that we have elevated the need to include it without actually forcing people to include it is in the data collection that we request from people. So if you collect data, if that's one of the things that people agree to, and I highly recommend getting a sign off, because we have a statement of interest that helps sort of reemphasize that, is that naturally forces people to adopt processes that makes it easier for them to report the data. So a number of our folks did the same sort of, put it in their rooming. It didn't look like that. It was literally a piece of paper that they attached to the folders or what have you. But it still created that sort of goal of building it in.
And what data were you asking them to track?
Well, we originally started with about 13 different points, and I'm happy to share you. We've condensed
That was one of our challenges. We were asking for so much data at the beginning, and people just.
Yeah, so we've really modified, and I'm happy to
Yeah,
talk about
great.
that offline.
And just I'll get to you, Deb, just a comment, since the rooming process started, before we knew about it, we had 4,000 some odd well, not all of them were conversations. 25% of that 4,000 completed a class or one-on-one. The other 3,000 were either invited or declined because we had that in our planning status.
We immediately saw how much of a difference.
Yeah, it went up by about, well, she was getting about 500 a month, so it went up about 10 times, 9 times. And for advanced steps,
We have 15 minutes left, so I want to make sure you have a chance to get through everything.
Okay. One other thing that I wanted to share about our outcomes,
yeah, go ahead.
okay, is that they had, the last year, they went from, the first year you saw we had 200. The last year we had over 2,000 conversations in Southern Colorado completed. So I wanted to get to that. And one thing that I think that is really important, and Bridget's going to be doing a workshop right after this, well, after
No,
the
2:30.
2:30 on concordance. But Kaiser, part of this is we found that concordance, people's wishes were known, honored, and followed, and Kaiser's at 99% this year.
For
So-
those who had
for
life
those who
care
had had.
planning, because
Yeah.
they get a death report of those who have had life care planning conversations. But just with that rooming process, we are also up to 400, from about 225 conversations a month being, 85% of those being completed, we're up to over 400 now.
It's
So
amazing.
it does make a difference.
And that's one thing that Sangre is working on. How can they start tracking? That's their next step. How can they start tracking the concordance? How can they make sure that this is being impactful and their wishes are known, honored, and followed? So that's their next, what they're wanting to do. So I just wanted to show you the last slide, and because since Brianna can't be here, I said, Brianna, send me a picture. So she sent me a picture of her and her daughter kind of in the corner. So thank you so much for your time, and I hope this maybe instills more into you to try to get out into your communities. I'm working for Kaiser. I said, can I go out and do this in my community instead of just with Kaiser? And they said, absolutely. Absolutely. We're invested. We're a nonprofit. We want to get out into the community and get this spread. So I think if you talk to other people, you can do this within your own communities. Any other questions?
Yeah, we have about 15 minutes yet for questions.
Or you can have the gift of time.
I have so many questions, I'm sorry. Being in rural New Hampshire, there's a lot of parallels here. So, my first experience with restricting choices was when I was actually with a home health agency trying to partner with Dartmouth. And the thing that kept coming up is like, ooh, we can't partner too closely because of the Starkey laws or da-da-da-da. So how did you get through that barrier working with an outside agency and not, looking like, or did you just ignore it?
I'm one of those social workers that likes to ask for forgiveness later.
There you go.
But Sangre de Cristo Hospice is one of our contracted providers.
Oh, right.
So that's where our in was. You've got to, I think that's the key, is looking at contracted providers to work with.
Also, when you're contracted, I find that that relationship is much more connected and like getting data back. and all that is much
absolutely.
easier. When they're independent, it's a little bit harder.
Oh, yeah. I mean, we need to document now when they enroll in hospice. I've got them down to, they call me immediately if they get a referral. So it's relationship building. I think that is key.
And I just want to add that when Nancy was hired for Southern Colorado, she had no program established whatsoever. She has developed a stellar program, and she is the top performing supportive care social worker in the state of Colorado for Kaiser Permanente.
For right now. Thank you very much.